Okay, today is shoulder and elbow day. So we're going to spend our time in the upper extremity. And as I promised at the very outset of the course, recognizing the various levels of expertise in the audience, that I will usually start each articulation with a discussion of some basic anatomy, a starting point. So I will spend the first 20 to 30 minutes just showing you some basic anatomy. Probably most of you know all of this anatomy. The first thing we do is take a look at the scapula, looking at its anterior surface, seeing what is regarded as the scapular body, the scapular neck, the coracoid process, the spine of the scapula, which terminates in the acromion. There are several other landmarks. There is a lateral ridge, which is a bone prominence on the anterior surface of the scapula, and there is one of two major notches in the scapula. This is the suprascapular notch. Evelyn Flizard talked about this yesterday. Through this notch travels the suprascapular nerve, and hence this is a site of nerve entrapment. As we look at the posterior surface of the scapula, we can see the spine, which again ends in the acromion. And if you look at the surface in the posterior portion, you can see that there are some ridges. These are effective for various muscular attachments, and we'll talk about those attachments in a little while. Here we see, although not well, a second notch, the spinoglenoid notch, located more posteriorly than the suprascapular notch. But the same nerve, the suprascapular nerve, travels through this particular area as well. As we look at a image of a scapula from the point of view of the humeral head looking toward the glenoid cavity, you can see the general shape of the glenoid cavity. This is not entirely accurate, as we'll talk about. We see the posteriorly directed spine and the acromion, the prominent coracoid process anteriorly. We can define an acromial angle. I'll talk a bit about that, and an infraglenoid tubercle for attachment of the tricep. So these are important landmarks. Now, one of the things that we're being called upon to assess more regularly on CT or MR imaging is something called glenoid version. This is not easy to do for a number of reasons, and I'll show you how the lines are constructed, but you'll appreciate perhaps why you might have some difficulty doing this in an actual case. This is the way the scapula and humerus would line up with respect to a horizontal axis of the body, and we'll talk a little bit more about this axis when we talk about the throwing shoulder. But this is not in the true coronal plane of the body. This is the coronal plane of the scapula at an angle with the coronal plane of the body. To figure out a glenoid version angle, you draw a line through the middle of the glenoid face, and this is kind of the line that you want to draw. So you're picking a mid-glenoid face level, and you're trying to identify the medial aspect of the scapular body, and that is often excluded from the field of view. So you may not even find that landmark, but if you can, you then draw the line through the mid portion of the glenoid face, and you continue it out as shown here. This is the coronal plane of the scapula. You draw a line that is tangent to this, as shown here, and then a tangent to the glenoid rim, and then you draw a line that is at right angles to the first line that you drew. You end up with an angle here, which is the glenoid version angle. Now, if you manage to accomplish all this, you run into a second point of difficulty because of the variability in glenoid version in normal persons. Taken from the literature, and there is some disagreement, the normal version of the glenoid face is between 2 degrees of anteversion and 9 degrees of retroversion. So in general, it is slightly retroverted. And to make things worse, if you were to do this experiment with all these lines, from top to bottom of that glenoid face, it would change with each level that you would be picking. However, having said how difficult it is, I would indicate that it does become useful, particularly in examples like this, where there is considerable joint disease, in this case osteoarthritis, and the orthopedic surgeon may be considering doing some sort of arthroplasty. Knowing the version of that glenoid face here retroverted, and other things such as the loss of bone stock of the scapula, and there are ways of accomplishing that as well, you're providing useful information to that orthopedic surgeon. Severe osteoarthrosis of the glenohumeral joint is encountered. Years ago, we said it was extremely rare. I think that was not correct. In general, in my experience, most of the time when you have severe OA of the glenohumeral joint, the humeral head migrates in a posterior direction. That's the usual way that it moves, as in this case. There are developmental conditions that also can lead to alterations in scapular shape. And this is an interesting one that goes by a variety of names, including hypoplasia of the glenoid neck and a denticulate glenoid, where there is a deficiency, particularly in the posterior margin of the glenoid. Although this may be asymptomatic and often is bilateral, some of these persons do have symptoms, findings of instability, often multidirectional. In a way, it looks like acetabular dysplasia of the scapula. We tried to see if there was an association with acetabular dysplasia, and many years ago we found no particular association. But you can see how the glenoid neck is hard to identify. The face of the glenoid cavity joins the body without a constriction in between, hence hypoplasia of the glenoid neck. I won't be talking more about this condition, but I would tell you it's a very difficult condition to assess because the posterior labrum develops as large as shown here and often separated from the glenoid margin. So trying to decide if there are acquired alterations back here or simply developmental ones becomes difficult. In this case, the anterior labrum was also abnormal, but hard to see in this image. Now, there are many, many muscles that are found about the shoulder girdle. Here is a scheme of their attachments as we look at the bones of the shoulder from the anterior aspect. The major muscle attaching to the anterior aspect of the scapula is the subscapularis muscle. It extends over and attaches in part, not in total, to the lesser tuberosity shown here. The short head of the biceps and the coracobrachialis attached to the tip of the coracoid process. There are, in fact, several muscles that attach along the anterior surface of the humerus. These are called the plate, P-L-A-T-E muscles, pectoralis major, latissimus dorsi, and teres major. And you can see their relationship to the bicipital groove. In the front, we can see the attachment of the supraspinatus tendon. The muscle we'll see better on the next view. So here we can see the site of origin of the supraspinatus muscle that travels mainly in a gentle horizontal direction to attach atop the greater tuberosity. A large muscle origin of the infraspinatus, which attaches to the posterior aspect of the greater tuberosity, and the teres minor, traveling from here to here. So when we talk about the greater tuberosity, we talk about the sit tuberosity, supraspinatus, infraspinatus, and teres minor. Complicating our assessment of MR images of the shoulder, the existence of many, many ligaments, some of which are shown in this drawing. A few words about these. We'll be talking about them in greater detail later on. The coracoacromial ligament runs from the coracoid process to the acromion. Shown here is a single sheet of tissue. It often is bifurcated, particularly as it attaches to the coracoid. And the more limbs of this ligament you see, apparently the higher likelihood of problems of impingement. The coracohumeral ligament extends in the rotator interval from the scapula right here. This is an important ligament. Later today, we'll be talking about stability of the biceps tendon, and this will be a major player in that particular topic. Classically, there are 3 glenohumeral ligaments. They're shown here, superior, middle, and inferior. That is a simplification of what may exist in your shoulder. All right, and we'll talk about some of the variations of those ligaments. The transverse humeral ligament is an interesting idea. It is said to represent these fibers that travel from the greater to the lesser tuberosity. Interesting because recent literature suggests it doesn't exist. Transverse scapular ligaments, you can see part of them here, relate to those grooves that we talked about earlier. Now, as you all know, to find ligaments, we first look for a low signal intensity structure, and we have to know where they run. This is a great view of what we usually see in an oblique sagittal image of the coracohumeral ligament, and in this case, very normal looking and outlined beautifully because of fat both above and below this ligament. As we'll talk about later this morning, obliteration of that fat and changes in that ligament are a well-recognized manifestation of adhesive capsulitis, and this is what they would look like. There are other findings of adhesive capsulitis that we will discuss later. Some of the components of the glenohumeral joint are not unique. In common with other articulations, it has articular cartilage, it has a capsule, and indeed it has a synovial membrane. One part of its anatomy that is not quite unique, the hip has it as well, is a cuff of fibrocartilage that surrounds the articular cartilage, shown here in this preparation in this general area. This is the glenoid labrum. We go ahead and do an arthrogram, and this is what it would look like, and there are several regions of the joint that have names. The first of these I would call the subscapular recess, shown by the arrow, a finger-like diverticulum that extends from the major part of the joint in a medial direction, as you can see, located mainly but not entirely beneath the subscapularis muscle and tendon. You should not call this a bursa, okay, because there's another structure nearby, the subcoracoid bursa, that is not part of the glenohumeral joint. So to remember, in fact, it is part of the joint, we call it the subscapular recess. It extends for a variable distance medially. It's greater in length in internal rotation, as you might suspect, than in external rotation. The second area is the axillary recess, sometimes called the axillary pouch. This hangs down like a dependent sac from the major portion of the joint. Its borders are bands of the inferior glenohumeral ligament complex. We'll talk a bit more about injuries to the axillary recess or sac later on today. And almost, but not completely, surrounding the biceps tendon is the bicipital tendon sheet. Extending for a variable distance within the bicipital groove, the distance it extends probably doesn't tell you whether there is an abnormality present, but if you don't see a tendon within the fluid, within the sheet, there's probably a problem with the biceps tendon. We can see the subscapular recess when there is fluid in the joint, and this is an instructive image to look at because it shows you what is generally considered to be the limit of the recess. This is the capsule of the glenohumeral joint. So you'll note the recess is kind of U-shaped as it extends over the top of the subscapularis muscle. You'll note that below it in this particular image, the reason I chose the image, is a second fluid collection, which is the subcoracoid bursa. The subcoracoid bursa does not communicate with the glenohumeral joint. It may communicate with nothing. It may also communicate with the subacromial subdeltoid portion, or bursa. So this kind of finding of fluid isolated to or dominating within the subcoracoid bursa may have significance. Bursitis, problems with nearby anterior supporting structures of the shoulder, those are things that come to mind. So know the difference between the subscapular recess and the subcoracoid bursa. It's not always easy to tell sometimes where the fluid is. Of all of the articulations of the human body, it is the glenohumeral joint that possesses the least inherent stability. It is the joint most frequently dislocated. There are a number of reasons for this. We'll discuss them in detail later, but I show you one on a coronal section. As you look at the size of the articular surface of the glenoid portion of the joint and compare it with the size of the articular surface of the humeral head, there is a major discrepancy. This does not make for a very stable situation. It's much like a golf ball resting on a tee. So the humeral head is not stabilized by the bony surface of the glenoid face. It's not wide enough. And hence the stability of the glenohumeral joint relies upon a number of other structures that we will cover. One of the structures that provides stability to the glenohumeral joint, and this is a short list of the structures that do so, but one of the structures is the rotator cuff. So let us start there. The rotator cuff consists of 4 muscles and their tendons. They're listed here. You know them very well. All of these muscles and then their tendons pass from the scapula medially to the humerus laterally, and not only support the glenohumeral joint, but channel the motion that takes place at that particular articulation. If we go ahead and look at what they might how they would be seen from a posterior approach, we can see the supraspinatus muscle, the large infraspinatus muscle here, the teres minor. If we were to do a sagittal section right through the scapula, this is what it would look like. It looks like the letter Y. Here you can see the Y shape of the scapula. This is the spine of the scapula, above it the supraspinatus, below it the infraspinatus and teres minor, and in front of it the subscapularis. So if you're having trouble deciding what tendons you are looking at laterally as you get to the tuberosities, go back medially in the sagittal plane, identify the muscles, and then follow them on sequential sagittal images as you extend toward the greater tuberosity. This is the appearance from the anterior aspect. The dominant subscapularis muscle, which in this particular drawing taken from the literature ends right here at the lesser tuberosity. Now, it is important you recognize that that is not the entire story of the attachment of the subscapularis tendon. 30 to 40% of it attaches below the lesser tuberosity to the surgical neck. So if you are not looking at the lower part, you are going to miss cases of disruption of that part, which may occur in people who have anterior glenohumeral joint dislocation. The second part of the story, often left untold, is the fact that fibers from the subscapularis are now believed to extend over and under the biceps tendon to reach the greater tuberosity. So some of them do not end at the lesser tuberosity, they extend to the greater tuberosity. This has dramatic importance, as you'll see when later today we talk about patterns of subluxation and dislocation of the biceps tendon. So what has been called the transverse humeral ligament may not be. It may represent cuff fibers, subscapularis, or as others believe, also supraspinatus tendon fibers. Because of the arrangement of the muscles on the posterior aspect of the arm, several spaces or apertures are created. This one, the most famous, the quadrilateral space through which the axillary nerve and the posterior circumflex humeral artery pass. It's an interesting landmark for you It often has a lot of fat and a lot of little dots and strands within it, so trying to figure out what is vessel and nerve becomes difficult. But it allows you to identify the nearby muscles, as I've done with labels in this particular case. And this can be useful because indeed you can see isolated muscle strains in one or several of these particular structures. Here at Terry's major muscle strain, this is something we see in our professional baseball pitchers. So I like that as a landmark. When we study the quadrilateral space, we look for findings of the quadrilateral space syndrome. All right, usually they are fibrous strands that you don't see, but if there is a ganglion cyst or something like that sticking into that space, okay, then you can consider quadrilateral space syndrome with interruption of the axillary nerve or posterior circumflex humeral artery. The rotator cuff, when intact, separates the glenohumeral joint from a surrounding bursa, the subacromial subdeltoid bursa, which, as I mentioned, may communicate with the subcoracoid bursa. A full thickness tear of tendons of the rotator cuff, supraspinatus or infraspinatus, allow communication of the joint and the bursa. A partial thickness, articular-sided tear of the supraspinatus tendon is visible when you do arthroscopy because contrast material passes within it. A partial thickness, bursal-sided tear of the supraspinatus tendon may be invisible or will be invisible to the arthrographer. Surrounding the bursa is a radiologist's friend, the peribursal fat plane, and you can kind of appreciate it on this image. This is a friend because you can see it with many imaging methods, including conventional radiography done with internal rotation of the shoulder. So this is what the normal looks like. You can see the fat around the humeral head. Now, I'd like to be able to tell you that if you don't see that, there is a significant abnormality of the shoulder, but that would be untrue. There's a higher likelihood there's something wrong, but it is not specific. Bursitis, rotator cuff tears, can certainly obliterate this particular fat plane, but it may be hard to see in very muscular people as well. So you should look for it, but the value is not great. It's probably pretty good, but not great. A second stabilizing structure, the glenoid labrum. As I said, it surrounds the glenoid cavity. I just show you the superior and inferior portions here, and by doing that, by being located like that, it widens and deepens the glenoid side of the joint. So it provides stability. We call that passive stability. That is a function. More important to us, of course, are the patterns of injury to this structure that occur with displacement of the humeral head. The glenohumeral ligaments classically are 3 in number, as shown in this particular drawing. We can see the superior and the middle glenohumeral ligaments and anterior and posterior bands of the inferior glenohumeral ligament complex. We are going to talk about variations. We're going to talk probably in some detail about the spiral or oblique ligament that we see as well, which I think is important. But these are the 3 classic ligaments. They're shown well in the Netter drawing because on the Netter drawing we can see the superior, the middle, and then a portion of the inferior glenohumeral ligament. On the Netter drawing, we can see there are openings between the superior and middle and between the middle and inferior ligaments, but the number of openings vary tremendously from one shoulder to another. It is these openings that provide communication from the major part of the joint and the subscapular recess, that diverticulum. So very little has been written about the MR appearance of these foramina, as they are called, but it does create some diagnostic problems sometimes. There are descriptions, anatomic descriptions in the literature of the variations in them. And here is the De Palma classification of the foramina. I'm not going to go through the various patterns, but you can see the size varies, as does the number and location of these apertures. The coracoacromial arch forms the roof of the glenohumeral joint. Passing from the coracoid process anteriorly to the acromion posteriorly, I've indicated many anatomic variations of this ligament. It is intimate with portions of the rotator cuff, as well as the subacromial subdeltoid bursa, which is colored by blue latex in this particular drawing. Now, as we will talk about, abnormalities of this arch can be associated with patterns of impingement. We'll be talking about that in the next lecture, all right? Second point I would make is that the acromioclavicular joint should really be considered a part of the coracoacromial arch. When we do MR imaging of the shoulder, we typically examine the patient supine. We put the arm at the side. We put the thumb up in neutral position, as shown here. I do not like internal rotation at all for assessment of the shoulder. I find a lot of difficulties when I look at that. And I frankly don't really like external rotation, but I like it better than internal rotation. But I would choose the neutral position as really the best position for looking at the shoulder. We use some form of coil placed upon the shoulder, a 14 to 16 centimeter field of view. We image in 3 basic planes. So let's finish up this first lecture by looking briefly at these imaging planes. We're going to get back to that later. From a coronal localizer, we could see the first of the 3 planes. This is the transverse transaxial, or sometimes or often called the axial plane. From the axial plane, we can derive a coronal plane to the scapula. Some like to plan this according to the supraspinatus tendon, but it's basically about coronal to the scapula. The problem with choosing the supraspinatus tendon, as we will talk about shortly, is that there are 2 muscle bellies and 2 tendons, and you want to choose the right one, all right? So this is basically what we call the oblique coronal plane. And the third plane is tangent to that joint, and this is the oblique sagittal plane. And you want to be sure that your oblique sagittal images go far enough laterally that in the last one there is no bone. If you have a bit of bone, you're probably going to miss some tears of the rotator cuff. So go beyond the tuberosities and the humeral head. Again, I promised a little bit reluctantly to show you the way I review the images. Not, again, that you should do this, but develop a plan that you do almost every single time you look at the shoulder MR. I start with coronals with a split screen, a fat-sensitive, fluid-sensitive side by side. I go to sagittal. I often mix the sagittal and coronal when trying to evaluate the rotator cuff. And then axial and sagittal I find very important together, particularly when you're identifying a labral abnormality in the axial plane. You try to figure out where it is, and I can tell you when you then put up your sagittal image and cross-reference, you'll be amazed how far off you were in figuring out where that tear was. So I always like to look at it cross-reference to the sagittal to figure out where the tear is. Now I'm going to introduce very briefly what it looks like in the coronal plane. I used to spend a lot of time on this slide, but I don't want to do that because I'm going to change this information in a few minutes. Having said that, these are the coronal images, anterior to posterior. So here we can see the subscapularis passing beneath the base of the coracoid, extending over to the lesser tuberosity. A little bit more posteriorly in the region of the acromioclavicular joint, we see the supraspinatus muscle. This is the intramuscular tendon of the anterior muscle belly coming over and attaching to the anterior facet, the horizontal facet of the greater tuberosity. We go a little more posteriorly, bottom left, we still see that we have supraspinatus muscle and tendon, and you'll see a portion of it is now attaching to an obliquely oriented facet. This is the middle facet. We go more posteriorly here beneath the acromion. We can appreciate the infraspinatus muscle, the main muscle belly. There are, in fact, 3 of them, but this is the main one. Here is the tendon. It is sloped up. It's extending kind of over the humeral head, and it, too, attaches to that middle or oblique facet. And then you can see one further landmark here. This is the posterior, sometimes called inferior or vertical facet, to which attaches the teres minor. Now, that's pretty good information. I will change it slightly in the next lecture, but that's kind of the way we look at the tendons. The year was about 1986, and I was just getting started in MR imaging of the shoulder, and a couple of the residents and fellows came to me. In fact, I was just getting started in MR, and they said, "What do you think of this technique?" And I've always been good at looking at the future. I said, "I think it's going to be worthless in terms of the musculoskeletal system." That's what I said, and I believed it, all right? And then they said to me, they were 2 research fellows in the MR division, "We're going to go back, and how about if we put gadolinium in the shoulder?" I said, "I don't know. It sounds like a good idea." That was the birth of MR arthrography. And these you're looking at are the original images that were brought back to me to look at. And boy, now I started to think this may be something really good. I wasn't sure what I was looking at, but I knew it was good. All right. Here's the contrast agent within the joint in the coronal plane. And this was certainly biceps. I had absolutely no idea what this was. We'll be talking more about it. And then they showed me the corresponding anatomic slice. And boy, I said, now you may really have something here. And that is how MR arthrography started. We published a number of articles on it. And all my friends wrote to me and said, this will go nowhere, because we have made MR invasive. Now, I know some of you go to a lot of meetings that deal with MR, and you've probably been to some that have talked about MR arthrography and say you never need it, okay? Here, that's an extreme view. Here we have, unfortunately, an extreme view the other way. We think we need it a lot. The truth is somewhere in between. If you don't do any MR arthrography, I think you're making your life more difficult. But don't believe anyone who tells you you never need it, because often that is told to you by someone who does a lot of teleradiology. The images and studies come from other sites, and they have no boots on the ground to do the injection. So they're going to say you never need it, just send us your standard images. You do need it, but probably we do too much of it, all right? But I was very impressed when I looked at that. Here is the second imaging plane in a cadaver, a more medial section, subscapularis, supraspinatus, infraspinatus, teres minor, well shown in the sagittal plane, and then a little more laterally. This was supraspinatus, infraspinatus, teres minor. I want to show you here the biceps sitting in the rotator interval. Well, those look all right. They brought me our first sagittal oblique MR images, and again, I was very, very impressed that we were seeing structures that really were more numerous, and we saw them with more detail. We saw portions of the biceps. Again, this is an old image, not great, but there were at least some soft tissue structures that we could see. We'll be talking about those. And then finally, the cross-sectional level, which I'm going to introduce briefly. This is going to be talked about in great detail when we talk about instability, but there are 4 basic levels we look at. This is the superior portion of the glenoid fossa. This is the level of the coracoid process. In a cadaver, you can see the coracoid process. You see the tissue just lateral to it, representing degenerative labrum and superior glenohumeral ligament. If we go ahead and look at an image, we can see the superior glenohumeral ligament, the labrum, and the biceps. This is level 1 that we look at. Level 2 is the level of the subscapular recess. That is the diverticulum I talked about earlier. In a section, this is what it would look like. Subscapularis tendon attaching to the lesser tuberosity. Here you can see part of the recess, and part of it is indeed in front of that tendon. In the corresponding MR, here is the tendon. There is the recess. You can see the labrum, and we see a little bit right here of a degenerative middle glenohumeral ligament. The third level is just below the subscapular recess. This is what it would look like. It's the level where the capsule attaches to the scapula. If you judge capsular attachments anteriorly, this would be a level that you might want to look at. I'll talk more about that. Again, a lot of degenerative labrum and ligaments in this particular case. And then finally, the lower level, inferior glenoid fossa. This is dominated by a thick capsule, which also contains the anterior band of the inferior glenohumeral ligament. And from our original cadaver, this is what we saw. And it's hard to see the ligament separate here. This is probably posterior band that we're looking at. So that's the background of the general anatomy.